Hey everyone, it's Nurse Sarah, and in this video I'm going to go over NCLEX questions and answers. So let's get started. Our first question says that a patient with asthma is prescribed to take inhaled salmeterol and fluticasone for long-term management of asthma. You observe the patient taking these medications. Which option below best describes the correct order and how to take these medications? So whenever you look at this question, you first want to analyze the medications. We know our patient has asthma. So they're taking salmeterol, which is a bronchodilator. And how a bronchodilator works is it opens up the airways. The other medication they're taking is fluticasone, which is a corticosteroid. That is going to help decrease inflammation of the airways, which is what a lot of patients with asthma need because they have inflammation in there. So how would you want the patient to take these? Well, let's think about how they work. Bronchodilator, just as its name says, is it's going to dilate, hence open up those airways. So would we want to take that first or second? We would want to take that first so we can get the airway nice and opened up. So then whenever we go to inhale the corticosteroid, the fluticasone, that can actually get in there and decrease that inflammation. So that's the order of how we want to do it. So let's look at our options and see which one's our answer based on that. A, it says salmeterol first. Okay, that's our bronchodilator. And then wait 5 minutes before inhaling fluticasone. That's our corticosteroid. Okay, that looks good. But let's look at the other options before we make a selection. B, it's saying do the corticosteroid first and then wait 5 minutes and do the bronchodilator. No, that's not going to work, because we need those airways open up so that medication can get in there, the corticosteroid. C, do the bronchodilator first, okay, then wait 1 minute and inhale the corticosteroid. I don't know. That's similar to option A, so let's keep those two in the back of our mind. The only difference is one we're waiting 5 minutes and one we're waiting 1 minute. So let's see what D says. D says to do the corticosteroid first and then do the bronchodilator. That's wrong. We'll get rid of that. So we're between A and C. So thinking about to how bronchodilators work, we need to give them time to work. So the patient needs to do the bronchodilator, wait 5 minutes so those airways can get nice and dilated, then do the corticosteroid. 1 minute is just not long enough, so 5 minutes is best. So our answer for this one is A. Our next question says that a patient with diabetes and hypertension is being discharged home. The patient will be taking Sotalol and insulin per sliding scale. Which statement by the patient demonstrates they did not understand your discharge instructions about Sotalol? So we're looking for an option that represents an incorrect statement by the patient that tells us they truly didn't understand our discharge instructions about Sotalol, and we got to re-educate them. Okay, so let's think about what Sotalol is. Well, that is being ordered for the hypertension. We know that the insulin is being ordered for the patient's diabetes. And Sotalol is part of the beta blocker family. And how I know that is because what helps me is to look at the ending of that generic name, and it's LOL, which is the beta blocker family. I know that beta blockers and diabetes can have an interesting thing together because they can cause issues, especially these non-selective ones. One thing that they can do is some of these beta blockers can actually increase a patient's blood glucose because it interacts with how the pancreas can make insulin, which could actually raise the blood glucose. Or whenever a patient has hypoglycemia, it can actually mask those signs and symptoms that patients typically get whenever they're hypoglycemic. So I'm already thinking in that realm about that. So let's just look at our options and go from there. Option A says this medication can affect my blood glucose level. It can, yes. So that's a correct statement by our patient. B, I'll check my heart rate and blood pressure daily. Yes, we want the patient definitely to do this because they have hypertension. We want them to check it at home to make sure that this medication, number one, is working, or we don't want this medication to be working too much where we're making them hypotensive. And it can affect the heart rate. Some patients don't tolerate beta blockers very well, and it drops them too low, like in the 50s, maybe sometimes 40s if they have too much. So we want them to check those things. C, a fast heart rate is an early indication my blood glucose has dropped. Okay, That right there is concerning to me because sotalol is really going to prevent that heart rate from being able to climb up to signal to your body you're having hypoglycemia. So that statement looks false. Let's look at D though. I will report any signs of shortness of breath or weight gain. Yeah, we definitely want a patient to do that because sometimes that's associated with heart failure, which can happen in patients, who are diabetic, hypertension, that increases their risk for cardiac disease, and that could be a signal of that. The heart's just not pumping well. So yeah, we'd want them to do that. So our answer is C, because these beta blockers, especially the non-selective kind, can mask those signs and symptoms. And we got to tell the patient that. So they just can't rely on tachycardia for a sign that their blood glucose has dropped. Our next question says that your patient is receiving half normal saline for hypernatremia. Hypernatremia is a high sodium level in the blood. What finding requires you to stop the fluid and notify the doctor? So we're looking for something that's abnormal that should not be presenting with this condition. Okay, A says decreasing sodium level, B increased urination, C confusion, or D polydipsia. So let's think back to half normal saline. What type of fluid is that? Is that isotonic, hypertonic, or hypotonic? That is a hypotonic solution, and sometimes hypotonic solutions are used to treat hypernatremia. Now, one thing we have to watch out with hypotonic solutions is that they can cause water to move from the extracellular space to the intracellular space, and if too much is moved to that intracellular space, the cell can start to swell. And whenever that happens, you're going to start to see mental status changes in your patient, like confusion. That wouldn't be good. So as the nurse, we want to be looking for things like that. So based on our options, what's not good? A decreasing sodium level. That's actually a therapeutic thing we want to see in our patient because they have high levels. So if it's decreasing, that's okay, but we don't want it to get too low, but it didn't tell us what the level was. So we can assume that it's decreasing, that's okay. B, increased urination. That is one of the things that happens whenever you give a patient fluids. You're putting more fluid in their system. We're giving them like free water, which is going to help lower that sodium level, which when you add more water in this space, you're going to urinate more. So that's expected. C, confusion. I have sirens going off in my head. That's not good because potentially we maybe gave them too much and we're causing cell swelling, so they're getting confused. And then D is polydipsia. That's where they have excessive thirst. That is a consequence of hypernatremia. So that's not concerning because we know our patient has high sodium, so that's expected. So the answer is C. That is something that is a cause for concern. Next up is a patient is in the acute phase of burn management. The patient experienced full thickness burns to the perineum and sacral area of the body. In the patient's plan of care, which nursing diagnosis is priority at this time? So we're looking for an option that is the most important. A lot of times with these priority questions, they will throw out options that, yes, pertain to the patient, but is it really priority at that time? So you really have to think about it. So it says A, impaired skin integrity, B, risk for fluid volume overload, C, risk for infection, or D, ineffective coping. So let's think back to the acute phase of burn management. That is our focus right now because each phase has its own focus. Typically there's 3 phases, and how I remember those phases is I remember the word ear. E is the emergent one, and this is the onset of the burn injury to restoring the capillary permeability. We're really going to focus on hypovolemic shock, respiratory distress, compartment syndrome. Then we have the next one, which is what our patient's in, the acute. It is where we have our capillary permeability stabilized. So a patient's going to have some diuresis going on. They're going to be losing their fluid to when that wound starts to close, has closed. And then we have the last one, which is rehabilitative, which is where the burn has healed and the patient is able to function again, but we need to be being there for them mentally and physically. So, since we're in the acute, let's think about what's going on with our patient. So, we take a look at those burns. The burns are on the perineum and sacral area. That's another red flag to you, because whenever you have burns in this area, get infected and lead to sepsis. So let's think about this. A, impaired skin integrity. Our patient has that. Is that one of those distractors? Is this really priority? Oh no, let's look at the other ones. Risk for fluid volume overload. No, this is diuresis time. This is where our patient's actually going to be at risk for fluid volume deficit because they're going to lose fluid. And then C is risk for infection. Thinking yes, because just the nature of our burns, we're trying to heal and they can get infected. And then D is ineffective coping. That's really for the last stage or phase, and they're not in that. So priority at this time is risk for infection, because infection can lead to sepsis, which can lead to death. Next, we have a patient who's admitted with hepatic encephalopathy secondary to cirrhosis. Which meal option selection below should be avoided with this patient? A, beef tips and broccoli raw. B, white rice and a vegetable medley. C, cucumber sandwich with a side of grapes. Or D, fresh salad with chopped water chestnuts. To answer this question, we have to understand what hepatic encephalopathy is, what's going on with the patient, because there's something going on with the patient that's going to require us to have them on a special type of diet until this passes. So with this, it happens many times because of liver issues like cirrhosis. And your liver plays a big role in detoxifying your body, but if our liver is not working, we cannot detoxify our body very well from toxins. So we will have the buildup, especially with hepatic encephalopathy, the buildup of a substance known as ammonium. And whenever this happens, it can cause major problems for our patient, because what happens is that ammonium is the byproduct of the breakdown of protein. So whenever we have the breakdown of protein, normally a healthy liver can take that substance and turn it into urea. But when we have cirrhosis going on, liver can't do this. So we get the buildup of the substance. Therefore, we want to make sure our patient is consuming foods at this time low in protein until they recover from this hepatic encephalopathy. So we want to look for options that wouldn't be good, because they need to avoid it. So we don't want them to have high protein food. So look at your options. Which options are high in protein, because that's going to be the answer. And the answer right there, anytime I see a meat, especially a red meat like beef, that's high in protein. So our answer is A, beef tips and broccoli raw. The next question says, the nurse sees the rhythm below on the ECG. The patient is unresponsive and has no pulse. The nurse calls the code blue and takes what step next? A, prepares for defibrillation. B, administers epinephrine. C, starts high quality CPR. Or D, notifies the physician. So the rhythm that you're seeing is a lethal rhythm. It needs to be addressed immediately. So the nurse was right in calling a code blue. And with this rhythm, what's happening is you're getting no cardiac output. Your ventricles are literally just quivering in your heart. And the next step from this rhythm is a flatline asystole. So all those options we're going to do. But what is the nurse going to do next? So we have the code team coming. They're going to come, run this code, and we are going to defibrillate the patient. We're going to give them epinephrine, and of course, their physician's going to be notified. But what we need to do while we're waiting on that code team to come, we need to be starting high quality CPR, because that is going to help get some cardiac output going on right now, because the heart is not doing it. So the next step that we would do is start high quality CPR. Then the code team's going to come. We're going to prepare for defibrillation, epinephrine, and then get the physician notified about what's going on with their patient. So our answer would be C. The next question wants us to identify the rhythm that we see on the ECG strip. So here we have a 6-second strip, and we need to determine if we have A, normal sinus rhythm, B, sinus bradycardia, C, first degree AV heart block, or D, second degree type 1 AV block, which is a Mobitz 1. So whenever we look at this, you want to start with the P wave. Look at your P waves. We see that there's one in front of every QRS complex. They're occurring at a regular interval, so our atrial rate is regular. Then when we look at, and when you count the P waves within that 6-second strip because they're regular, it's about 70, our rate. And then our QRS complexes are less than 0.12 seconds. They're occurring regularly, and they have a rate or ventricular rate of about 70. So our atrial and ventricular rate match. That is good. And we have our T wave. So with this, we have our rate of 70, and you may, whenever you look at it, you may think that we're dealing with just normal sinus rhythm because it meets the rate criteria. It's regular. So we can rule out B. It's not sinus brady because it would need to be less than 60 for that. But let's take a closer look at it. You want to look at every little part you can, especially those PR intervals. Sometimes those are overlooked by whenever they're first starting out looking at rhythm strips. But our PR interval is very important. So that is measured before the P wave, and it ends right before the QRS complex. And that should be about 0.12 seconds to 0.20 seconds. Anything less than that, it means it's short. Anything greater than that, it's prolonged. On this rhythm strip, it is definitely greater than 0.20 seconds. So we have some type of heart block. We don't have normal sinus rhythm. If you're first looking at that, you may have thought it was sinus rhythm, but it's not. It's some type of heart block. So let's figure out, is it C or D? Well, D, a Mobitz 1, a second degree type 1 heart block, it's a unique one that what happens with that is that your PR interval gradually lengthens. It gets longer and longer until you drop a QRS complex, and then the pattern repeats itself. And that is not the case here. That PR interval is staying the same, but it's prolonged. So our answer is C. This is a first degree AV block. Now, these type of heart blocks are, I would say, the least severe of all the heart blocks. And typically, if your patient's not having signs and symptoms, there's no treatment needed for it. Next, our patient is 2 hours post-op from cataract surgery in the right eye. You're collecting vital signs and assessing the patient. Which finding in your patient after the cataract surgery requires you to re-educate the patient? So we're there assessing the patient. They've just had surgery 2 hours ago, and we have found them doing something that we need to re-educate them on because it could cause complications post-operatively. So what could that be? Well, A, it says the patient is asleep on the right side. B, the patient is wearing the eye shield while asleep. C, the patient fell asleep watching TV. Or D, the patient is not wearing their glasses. So with cataract surgery, we have it in the right eye. So with this, we want to make sure that our patient is being able to rest and recuperate. But whenever they rest, the patient should sleep on their non-operative side. So they should sleep on the left side, not the right side, in this case, because the patient had surgery on the right side. So they should be on their left side. The reason for this is because we don't want to increase pressure on that operative side. Now, the patient should wear an eye shield while they're sleeping during naps, especially to protect that eye, because accidentally, whenever you're half asleep, you can wake up and rub and scratch your eyes. You really don't know what you're doing. So that shield's going to help protect that. And it's okay for the patient to watch TV, and the patient doesn't have to be wearing their glasses unless they're needed at that time. So our answer is A. We need to re-educate the patient because they shouldn't be on that right side, they should be on the left. The next question says, a 25-year-old patient presents to the ER with unexplained paralysis from the hips downward. The patient explains that a few days ago her feet were feeling weird and that she had trouble walking. She is unable to move her lower extremities. The patient reports suffering an illness about 2 weeks ago but has no other health history. The physician suspects Guillain-Barré syndrome and orders some diagnostic tests. Which finding below during your assessment requires immediate nursing action? A, the patient reports a headache. B, the patient has a weak cough. C, the patient has absent reflexes in the lower extremities. Or D, the patient reports paresthesia in the upper extremities. So with Guillain-Barré syndrome, what's happening is that your immune system is attacking your nervous system, particularly those myelin sheath on your nerve cells. And a lot of times what happens is that the patient has had some type of illness about 1 to 2 weeks ago. They recover, and then this weird paralysis and weakness comes on, and it can affect really anyone of any age. So what happens, how this tends to start, is it starts in the lower extremities, and that paresthesia will progress to paralysis and it migrates upward. And the respiratory system, as it migrates upward, can become affected, leading to respiratory failure. So here our patient has some issues going on, and our question wants to know what finding, if we find, requires immediate nursing action. So based on how this disease progresses, we are really worried about the patient's respiratory system. So that's something you want to be thinking about whenever you see this syndrome, Guillain-Barré, because how it progresses, because eventually they're not going to be able to breathe, and we're going to have to do that for them through mechanical ventilation. Our answer with this would be B. It's a respiratory problem, which puts it high up there, and that's an immediate nursing action. So the patient having a weak cough would require us to respond. Our next question says the nurse is performing a head-to-toe assessment and will be assessing the abdomen next. In what order should the nurse assess the abdomen? Number the steps. So we're going to number these steps 1, 2, 3, or 4. We have percussion, inspection, palpation, auscultation. So for all the other body systems other than the abdomen, we will follow the sequence: inspection, then palpation, percussion, and auscultation. However, with the abdomen, we have to change it up a bit, where you're going to do auscultation second instead of last. So the order for the abdomen will be first inspection, then auscultation, then percussion, and palpation. And the reason we want to do palpation and percussion at the end is because we're going to have to go and actually touch the abdomen and the intestines and everything, and we can alter those bowel sounds. So we want to make sure we're listening first before we go in there and start touching. So we save that till the last. Next question asks, which characteristic below is found with a pleura friction rub? Is it A, pain with coughing, deep breathing, or laughing? B, disappears with suctioning. C, high-pitched. Or D, auscultated in the smaller airways such as the bronchioles. So let's think back to what a pleural friction rub is. Well, that is our lungs. Don't get that confused with a pericardial friction rub. That is the heart. But here we're dealing with our lungs. So a lot of times what this is you have layers that surround your lungs, the pleural layers, and normally there's this little space in between it that allows those layers to just glide over one another while you inhale and exhale. But sometimes when those layers get inflamed, that doesn't happen. That space decreases between those layers, and those layers rub up against each other, and it's quite painful for the patient. So when you listen to the patient, you're going to hear this low pitch, not high pitch, low pitch sound that sounds like a harsh grating noise, like sandpaper. Some people compare it to Velcro, just rubbing up against each other. And it's not affected by suctioning. And the patient, one interesting thing is that when they cough, they laugh, they deep breathe, it's actually going to hurt worse. So that is a big thing you're going to see with that. So our answer is A. The next question says a patient with preeclampsia is started on magnesium sulfate. The nurse knows to have what medication on standby while the patient is receiving this medication. So we're looking for the antidote to magnesium sulfate in case this patient becomes toxic on this medication. Is it A, acetylcysteine, B, calcium carbonate, C, oxytocin, or D, calcium gluconate? Let's think back to preeclampsia. What is this? Well, this is a type of hypertensive disorder that can occur during pregnancy. It tends to occur after 20 weeks of gestation, which is that half-week point between a typical 40-week pregnancy. Now, unfortunately, preeclampsia can turn severe and turn into eclampsia. So whenever we start getting there is a high risk of seizure activity, and we don't want a pregnant patient to have seizures because that can affect their life, the baby's life, lead to coma and death. Therefore, they are sometimes started on magnesium sulfate, and magnesium sulfate can help decrease the risk for seizures because our central nervous system is really stressed out. The patient can have exaggerated reflexes known as hyperreflexia. Whenever you check those deep tendon reflexes, they'll be like 4+. So our magnesium sulfate can help relax things. But When we're giving magnesium sulfate, there's a risk also of giving them too much magnesium. So we want to make sure that we have the antidote on standby in case we have to give that. And signs and symptoms that they're magnesium toxic would be that we have the opposite with their reflexes. It is their deep tendon reflex are decreased or absent. So you'd always be checking those while you're administering that. So what is the antidote for that? It is calcium gluconate. So our answer is D. Next up is you're providing care to a 1-month-old infant who is hospitalized. The parents are unable to be at the bedside and the infant is crying. Select the appropriate nursing interventions for this infant. So we're going to have more than one answer, and we want to pick things that go along with this child's age. So think back to pediatric nursing and what we do for each age group. Some things, these options that you're going to have are not going to be relevant to this patient, maybe for an older infant. So with a 1-month-old infant, this is an extremely young person. They are really just needing their needs met because they're trying to develop trust with their caregiver. And here we're told the parents aren't there. So what do you want to do with this patient to help them when they're crying? Is it A, let the infant play with crib mobiles, B, swaddle the infant, C, attempt to play peekaboo with the infant, D, rock the infant, or E, distract the infant with a toy? So at this age, we want to, as I pointed out, meet their needs very promptly because we're establishing trust. So appropriate interventions for this 1-month-old would involve swaddling and rocking. The other interventions are really appropriate for older infants because at 1 month old, they don't have the coordination and the ability to play with crib mobiles. They don't have the cognitive ability to understand or play peekaboo, and they're not going to be distracted with a toy. So our answer is B and D, swaddle the infant and rock the infant. Okay, so that wraps up this review over NCLEX questions and answers. If you'd like to watch more videos in this series, you can access the link in the description below.